Welcome to today's webinar about artificial intelligence in eosinophil disease research featuring Dr. Puanani Hopson. My name is Jennifer Roeder. I'm a communications consultant for APFED, and I'll be moderating today's webinar. We are pleased to have Dr. Hopson join us today. She is a pediatric gastroenterologist at Mayo Clinic in Rochester. She has research and clinical expertise in aerodigestive and esophageal disorders, specifically eosinophilic esophagitis and gastroesophageal reflux disease. Some of her research at Mayo Clinic has included development and validation of artificial intelligence model for evaluating esophageal biopsies for patients with EOE. Welcome, Dr. Hopson.
Thanks for having me, Jennifer. Okay, I'll go ahead and get started. Let me share my screen. So thanks again to APFED for inviting me to come here. And this is a really great opportunity to share with you some of the things that I've been able to learn about artificial intelligence research within the field of eosinophilic diseases. So here are my disclosures. And really what I want to focus on today are questions. So what is artificial intelligence? How is it being used in medicine, specifically within atopic diseases, within EOE? And what does the future look like for AI, specifically with a caveat of eosinophilic diseases? So artificial intelligence, term you may hear very frequently, both within movies, within social media. It's in everyday life. It's evolving. It's really hard to ignore. It's present in several industries: education, transportation, media, manufacturing, finance, customer service, and healthcare, which is what we'll be focusing on today. So there's no single one definition of artificial intelligence, but in the concept of it is it's a computer program that mimics human cognitive functions to perform these functions that we associate with human intelligence, such as learning and problem solving. And within that category of artificial intelligence, you have machine learning and deep learning. Machine learning is where a program can automatically learn from labeled data. Over time, the algorithm will learn, and then this can be applied to certain clinical settings. And then you have deep learning, which is, again, deeper, and it thinks about more networks. Think of deep learning as like several different layers and data points that it all goes into one learning algorithm that can detect relevant features of the data, and it's more of a self-teaching system that is trained with, again, many neural data sets. So this is kind of the encompassing fact of artificial intelligence. You have these two types of learning methods within it. And within machine learning, you can teach the algorithm in certain ways. The two most common ones are in a supervised or an unsupervised setting. So supervised means that the model learns from labeled data. So in this example, the top, the model is that brain picture. The labeled data are pictures of apples and a label that says, these are apples. So when an apple is, shown to the model, it can say, this is an apple. Very simple supervised learning technique. Unsupervised is a little bit more complex. This is where you give it unlabeled data. And so you would show the model pictures of different types of fruit. And then the model itself will develop its own pattern and recognition of different things within each data point, or in this example, a photo, and be able to give you an output that says, here's the patterns that I see, and these are the categories that I'm putting them in. And so the unsupervised learning type is quite unique. An example of this would be, like grouping customers based on their buying habits, which we see quite often, through Amazon or social media and things like that. And so the unique thing about this is the algorithm within this model. Some people say it's like somewhat of a black box because you don't know what the model is actually doing and how their algorithm is developed. So I think it's quite cool and unique. Last is called reinforcement learning. And this one most closely resembles how you learn, how people learn naturally. This is type of learning where the computer learns by interacting with its environment and receiving feedback that then it takes to learn and augment the outcome of the goal or the output of the algorithm. An example of this would be learning to teach or teaching a vehicle how to park or drive on its own. There's different inputs it's getting from its environment that it's then turning into its algorithm for the output of successfully parallel parking, for example. So those are the types of learning models that you would do in order to create your artificial intelligence algorithm. And, artificial intelligence, again, like I said, is in everyday life. Some common examples would be like your spam folder or your junk mail. That is a very specific supervised model where someone had said, whenever you see this word in an email, like buy now, that should probably be labeled as spam or junk mail and should go into a different folder. And so it's a kind of a simple, easy feature to know. And that's artificial intelligence that you interact with every day you open up your email. Another one to think about is like facial recognition, where, for example, Facebook will identify who's tagged, who's on your photo and recommend that you tag this person. Another option of facial recognition you probably interact with at the airport, with global entry or airport security. Another example of artificial intelligence is your virtual assistants, like Siri, Alexa, Google. I'm saying it quietly so mine don't go off in my office here. And then social media, tons of AI within social media. The ones I mentioned before about facial recognition, also with recommending people that you may know. I'm always surprised, I'm like, oh, actually, I do know that person. But also ad targeting. So AI is all throughout social media, and we've experienced all that too. Credit card companies use AI specifically for fraudulent transactions or also for identifying like spending patterns and stuff like that. And transportation, this one's pretty cool. I mean, we know that, flight management systems for pilots are so advanced these days, the GPS, monitor sensor, position tracking, that the pilot's main job is just to land and take off, and the rest is all automated, and it's quite amazing. And then also, maybe we'll experience transportation a lot more personally with self-driving vehicles in the future too. So it's an everyday life. Now let's think about how it's in everyday medicine. So electronic health records, adopted almost ubiquitously now in the health field. It's hard to escape those. Medical databases, for example, like identifying drug interactions for a patient. Those are quite vast, and that's just one very tiny snippet of it. Wearable technology, so your Apple Watch that you're wearing, or maybe a EKG monitoring device for cardiology detecting atrial fibrillation. Endocrinology has unique, definitely wearable, quote unquote, wearable technology with glucose monitoring for type 1 diabetes, where your glucose monitor results are paired with your smartphone and can be sent in real time to your physician or go into an algorithm to notify you if you're at risk. Neurology has unique devices now that can detect seizures, devices that you can use with your smartphone to assess your gait, your posture, if there's a tremor, specifically if you have underlying diseases like multiple sclerosis or Parkinson's. And then when we think about diagnostics, imaging is everywhere within medicine, whether we're looking at a biopsy sample, an X-ray, a photo of skin, an eye picture of your eye, those all can be, digitized and put into an algorithm and really can help clinicians develop diagnostic abilities and tools to really, focus in on a diagnosis for you. So how is AI in, allergic, atopic diseases and EOE? And I think that's where we're going to shift next, is focusing on atopic diseases, which, in patients that I treat with eosinophilic esophagitis often have these comorbid atopic diseases, whether that's, asthma or eczema. And so I think it would be interesting to see how AI is in this currently. So when it comes to atopic dermatitis, artificial intelligence holds this potential to improve your clinical diagnosis. It's possible to even individualize your care, personalize treatments, and then kind of predict outcomes. And that's kind of what AI does in most disease states too. But there's a few studies that I want to highlight for atopic dermatitis. One where an algorithm was used to identify patients with atopic dermatitis just from the medical records. So unsupervised learning, giving an AI model health records, data from that, and they're able to then pick out patterns on who has atopic dermatitis and doesn't. And that can be really helpful, one, to identify patients, and probably to some degree start to identify and go further and understand severity too. And the next is one that used photos of skin. And these photos were then taught into an algorithm and were able to detect atopic dermatitis versus normal skin. And then the other is looking at something called deep phenotyping of atopic dermatitis. And this is a term that's used to really find like observable traits that represent a unique, like biochemical, specific patient population, and specifically in this category, the severity of atopic dermatitis. And so they took tons of clinical data points in this huge data set, labs, age of onset, personal history, and were able to find patterns in specific features. So factors associated with increased probability of having severe type of atopic dermatitis. It was based on certain age groups, age of onset of your atopic dermatitis, serum IgE levels, specifically those that are quite high, eosinophil, peripheral eosinophil values that are high, any other atopic stigmata that you had present, male predominance, and then physical activity, which is unique. I didn't realize that physical activity may be a factor in this, which is quite unique. So low physical activity is a portion in a risk factor for severity, and then smoking. So this is an example of how you can take this tons of data points, and maybe you notice something in a patient population or within a family member. That's just one point in time, and this looks at several and really figured out patterns, and I think it was a pretty great study. So next is looking at atopic disease for asthma. Again, still holds that potential to improve your clinical diagnosis, but I think asthma is a little bit different than atopic dermatitis in AI, where there's possibility for wearable technology to improve monitoring and classifying disease severity. So a few studies that I found, one looked at a wearable sensor that was sending recorded signals of respiratory sounds to a smartphone and was able to detect wheezing. The other used health records to identify asthma diagnosis and predict asthma status. So similar to the atopic dermatitis one, using records to say, I found a diagnosis, and now this one takes it a step further where I can predict their type of asthma, the severity, the status of it. Another looked at carbon dioxide waveforms from capnography to identify asthmatic versus non-asthmatic patients. And then the last analyzed wheeze sounds from an asthmatic patient to identify the severity of their asthma, whether it's mild, moderate, or severe. And this was tracheal-related wheeze sounds. So there was a sensor that was placed on the skin near the trachea, and these sounds were then, pieced out and categorized, and were able to be quite sensitive and specific as predictors for asthma severity levels. And so I'm sure you're saying, like, doctors know how to hear wheezes, and they can diagnose asthma severity from many different things. And so how does this help? And yes, the machine can help with this. And I think more importantly, it's thinking about how the physician and a machine device can quickly, with the combination of the two, determine the severity of your asthma or even the diagnosis of it, and get you to treatment much faster, or a more specific treatment based on the severity. And so I think it's really cool to see how this may work in tandem with physicians when it comes to asthma. And then now taking a step further and thinking about eosinophilic esophagitis. the AI in eosinophilic esophagitis, I think, is just at the cusp right now. I'll go through some of the studies that I was able to find, but all in all, there's around 15, maybe a little bit more, that have really been coming out, and they've all started within 2018 and beyond to now. So I think we're still at the infancy of AI and EOE, and I'd like to share a little bit more of that with you. So thinking about the background of EOE first, we all know it's a chronic immune-mediated and antigen-mediated esophageal disease process. Our primary diagnostic tool is the biopsy. And that peak eosinophil count is what we all use as clinicians to identify active disease or remission. And that's a eosinophil count greater than 15 eosinophils per high-powered field. There's other histology scoring system that we use on the biopsy that your physician may be using. And then there's also a scoring system that we use when we look in with endoscopy. But at the end of the day, there's going to be pitfalls to every diagnostic tool that we have. And we really rely on that peak eosinophil count at this time. But hopefully, what I'll share with you is that maybe we'll be able to expand that further in the future. So how can AI improve EOE? I think there's many opportunities. Like I mentioned, you're thinking about innovating new and non-invasive diagnostics, improving detection, even expanding on that definition of peak eosinophil count, providing personalized treatment plans, and really preventative care too. So like I said, the current literature is really early in its infancy. There were a little over 15 studies that are using specifically AI algorithms for EOE. Starting from 2018 until the most recent was October that I was able to see was published of this year. And majority of them use biopsy imaging analysis, which is the project that I was on here at Mayo as well, which I'll share with you. Some use a new diagnostic mRNA transcript from biopsies, which is really interesting. And then others take a different approach using endoscopic photo analysis. And that endoscopic photo analysis really started back with reflux disease, Barrett's esophagitis, and esophageal cancer using endoscopic photos. And so they're kind of translating that over to the EOE world, and I'll share that with you too. So let's start with the biopsy analysis. Why do we need AI here? So there's shortcoming in our diagnostic criteria. One is there's some selection bias, thinking of finding the areas of highest eosinophil count. There's variability within these high-powered field areas, and then accurate counting of eosinophils. So I put this picture up here so you can get an idea. The photo on the left, this is what a biopsy slide would look like for a pathologist who's zooming out completely and seeing the entire biopsy slide. And again, this is a small, tiny piece of tissue that your gastroenterologist probably got, and then they sliced it extremely thin and then laid it on the slide. And so there's several layers of the small tissue that the pathologist can view, and this is just one of them. So that's that bird's eye view of looking at the biopsy as a whole. And then that red box would be the pathologist zooming in on these quote unquote high-powered field areas, and that's what's depicted there in A. And in those high-powered field areas, that's where you get your peak eosinophil count. So that's where they start to read out on the biopsy, on your report, what they're seeing in terms of like the dilated intercellular spaces, the peak eosinophil count, and things like that. So that is where, in seeing this picture, you can kind of see where there's some shortcomings. Like, why would I choose that area over another? Am I counting the right area and things like that? So you could see how quickly within just looking at a biopsy, you may have some variability in what you see. And so that's where I think AI can really be helpful. So the current AI technique uses these convolutional neural networks, just like that deep learning network, right? That's classifying images and then able to kind of give you an output. Maybe that's your peak eosinophil count. Maybe that's other parts of the biopsy. But the unique thing that I want to mention is with AI and all the research that's going on right now, looking at biopsy samples, is you're able to look at the entire biopsy. It would take a pathologist hours to give you what this AI model is able to give you in an entire biopsy sample, not just in this small high-powered field. So it's really, really cool. So what we did here with Dr. Moreira and colleagues here was it was a technical validation of an AI pathology model. And we were able to find that it's a high accuracy in recognizing EOE based on histologic features that are standard for diagnosis of EOE. So our model looks at cell recognition, segmentation, so looking at different layers within that, also cell density within that high-powered field, and then spatial distribution of cells. And so I'll show you some examples of that so you can kind of see what I'm talking about here. So when we think about cell recognition, here's that same biopsy slide that we're zoomed in on a high-powered field. And yeah, maybe you can pick out some of those small red cells. Those are eosinophils. So pathologists would be counting those, looking at other cells too, maybe. But what this model is able to do is it's labeling eosinophils now in green, and it's also looking at different lymphocytes here in blue and squamous cell nuclei in red, looking at all of the different cells in there. And it's even able to kind of give you spatial relationship of these cells, both to each other, to themselves, within their own cellular class. So it gives you an idea of, quickly showing you, number one, how many eosinophils are in this high-powered field area, or maybe the percentage of eosinophils in the entire biopsy, or percentage of different cells. Maybe eosinophilic esophagitis, we're not counting the lymphocytes. Maybe we should be. And so I think it's really unique to think about how many patterns may be developed by just this tiny part and how many data points we have just from here. So that's cell recognition. Histologic layers. So within a biopsy sample, you have different layers of the tissue. And in this large biopsy sample here, you're able to, the model is able to really segment out these different layers and tell you what percentage of these layers are there in the entire biopsy. This top layer here, blue and green and red. So these layers will be expanded if there's different types of inflammation going on. And so to what degree they're expanded, what percentage of the biopsy, I think would be really unique to see how it goes going forward. These yellow area here called dilated intercellular spaces, which are a unique feature of inflammation, and I think maybe a more unique feature of EOE that we'll come to recognize. So we'd be able to look at percentage of layers, a percentage of each layer in the total biopsy, as well as within a high-powered field area. And then looking at those dilated intercellular spaces, so on a really, really super high-powered field area, you could see these like kind of white areas outlining almost like halos around these cells. And the model can label these and identify, to what extent that is there. And so this shows 3 different patient biopsies. So the top one, you can see there's probably a lower percentage of those dilated intercellular spaces. So maybe their disease process or the inflammation actually isn't as severe as, say, this lower one, where not only do you have disruption of the mucosal barrier, but you have tons of dilated intercellular spaces. So to what degree this can be helpful from a whole scale and from a histologic high-powered field area, I think will be interesting to find out. And fibrosis. So this is like a buzzword for EOE. In kids, we want to prevent fibrosis. In adults, we're treating fibrosis in terms of scarring and narrowing strictures. And so we have in our EOE histology model that we use, we're able to pick up fibrosis and specifically looking at the lamina propria bottom layer where fibrosis will happen. The model will look at a ratio of this red to green. So red is that lamina propria layer, green is this collagen. And so there's a certain ratio that says this is a little bit higher than it should be. Maybe this is more fibrotic than others. And I think going forward, we may be able to develop a pattern to recognize subtly patients that would be able to, predict maybe their response to treatment or predict their likelihood of developing a stricture or fibrosis. And then the last part, I mentioned when you look at the biopsy, the pathologist has to find that high-powered field area and decide, this is the one I'm going to count and provide you, the clinician or the patient, your result. This is a way to identify the best high-powered field. And a lot of the AI models the other AI models that are currently being developed use the same technology too, where they look at the entire biopsy and identify, in this specific case, eosinophils. So in what area of this biopsy are the highest concentration of eosinophils? As easily depicted here on the slide E, where these purple areas are areas of highest concentration. And then in fact, the red dots are areas where there's eosinophilic abscesses. So these may be clue you into the best possible place to count your eosinophils and actually give your diagnosis, or even look at the biopsy as a whole and identify how many of these high powered field areas do we have. So I think it hones in on the right area to count and may give you a more accurate understanding of your eosinophilic disease. So that was just our model. Others have used similar algorithms to identify these biopsies. Saeed and colleagues from the University of Virginia had 2 great studies looking at similar analysis and algorithms showing high accuracy in identifying EOE, and then looking at patterns in response to treatment and remission. And so this was quite interesting. You could see in this box here, at the time of diagnosis, the percent of tissues classified as EOE was quite high. And then once you reached remission, your percent of tissue that's classified as EOE based on their criteria in the study was much lower. So the percent of tissue involved was much lower, but even more so if you had remission and you were asymptomatic, as opposed to those who had remission based on quote unquote our peak eosinophil count that we use to classify remission. However, they were still symptomatic. And I know that I experience this often in helping my patients, try to understand, are you in remission clinically, or are you in remission histologically, and should we treat those 2 differently? And clearly, this group was able to find at least a difference within the percent of the tissue that's seen with EOE. They also looked at a location analysis. And within this, they were able to find unique patterns. And so specifically, when we biopsy different types of the esophagus, the distal, the middle, and the proximal areas, the middle actually had the highest amount of eosinophil count. There was also those with strictures and non-stricturing had a different amount of eosinophils. And then those that responded to a 6-food elimination diet, also had a little bit higher eosinophil count. So to what degree this is, and they're just looking at one specific thing, and their model, and including other algorithms, are able to look at, if you can imagine, if we can go beyond just thinking about eosinophil count, right? So this may even be way more, narrowed down into focus to find patterns going forward. So really interesting things probably coming out looking at biopsy analysis. There's a few more, but I wanted to jump from looking at the biopsy analysis and algorithms to actually looking at mRNA patterns from the esophageal biopsies. And colleagues out of Boston and Harvard took a look at esophageal biopsies from pediatric patients, those that had food impactions and those that didn't, and found a very specific mRNA pattern that was to be able to differentiate the 2. But within this, they found that there was no difference when you looked at eosinophil count, histologic features, or IgE levels. But when you went down to the mRNA profile, there were distinct differences, specifically within the mast cell transcripts expression, Th2 cytokine expression, and then smooth muscle function regulators being expressed as well. And so in this really cool model, you can see control here on the left, eosinophil EOE without food impaction had a very different pattern compared to EOE with food impaction. And again, this is looking at mRNA patterns. So I think this is a really unique thing that definitely combined with the biopsy would be pretty amazing to see going forward. Let's change the focus now to looking at endoscopic analyses. So when we look with endoscopy on the inside, we have a scoring system that we can use to identify EOE. And so that's looking at edema, rings, exudates, furrows, and strictures. And we call it an EREF score. And so with all intents and purposes, this EREF score can be really helpful to predicting, diagnosis of EOE, remission, But it's not completely needed on its own, because biopsy is still kind of our standard diagnosis and something we really hang our hat on at the end of the day. There are shortcomings in the endoscopic criteria. It's subjective. It may differ among level of training of your endoscopist. And then there's children that have no endoscopic abnormalities yet have EOE on their biopsy. So we can't hang everything on the endoscopic criteria, but if we think about different AI techniques, it uses the same neural networks that classifies images based on EREF score. And so 2 studies were looking at this. The first looked at how the photos look and identified highlighted areas of relevance, as specifically being able to teach the model to identify those EREFs, those edema, rings, furrows, strictures, and exudates. And so they had a high sensitivity to identifying patients with EOE based on simply the EREFs of these photos during endoscopy. And then another study looked very similarly, identifying EOE based on endoscopic images too, and showed that they had a higher accuracy compared to the endoscopic, to the endoscopist EREF score in identifying EOE. So, both of these, and I like the second study used the term optical biopsy to enhance the physician's detection of EOE, which I think is a very unique term. But I think that there's some unique ability to use this maybe in real time as you're doing endoscopy. These models were developed based on one photo at a time and not a real-time video, but there are really unique GI algorithms looking at videos and diagnosing gastric cancers and colon polyps and things like that I think we could probably adapt to using it real time for EOE. Now, there's some limitations to just looking at endoscopy, and those are the ones I've stated before. Some may have a completely normal score, and we still rely on those biopsies. In one of the models, there was some patients with candidal esophagitis had a similar score with those with EOE, so the model couldn't separate those 2 clinical entities. So regardless, biopsy is still definitely needed, but I think this is a unique opportunity to see how AI can be applied to other areas. So in summary, thinking about AI, it continues to advance both what we do in our everyday lives, but in medicine, it is expanding our diagnostic techniques. It gives us an ability to have unique monitoring for patients and improves our knowledge of the disease process. And I think in thinking about AI and EOE, it is very early in its development. Currently we're identifying how it can help us analyze biopsies and endoscopic images, but I think it can go even further in looking at different biomarkers and how that fits in with a huge pattern of biopsy findings and the endoscopic findings. So I think, as I said before, we're really on the cusp of everything. And I'm really excited to kind of see how we go from here. The other thing to mention is that within, I presented some AI models with EOE specifically, so eosinophilic esophagitis. Eosinophilic gastrointestinal disorders have really the same shortcomings. And although we haven't applied these models yet to gastric biopsies or duodenal biopsies, I think once we develop something with EOE, it can easily be applied to those disease entities too, and we may be able to find more unique patterns. So I think that the future is pretty bright, and I'll be interested to see, if I give this talk next year, we'll have, tons more research to present, but I do think it's evolving quite quickly, so it'd be exciting to watch. And that's all for what I wanted to chat with you guys about. I can take questions now or anything.
Wonderful. Thank you so much for such an in-depth tour of AI research. It was interesting to hear both about your work as well as the research that you've been reading about. At the very beginning of your talk, you talked about 3 different types of AI learning models. Which was used in the research that you conducted?
Yeah, so we used deep learning models, so several networks and layers. So not only looking at just the eosinophil count, but looking at several layers within the algorithm at spatial relationship and whatnot, to really have several networks into the system to develop the output, which is giving us maybe a percentage of eosinophils with an entire biopsy. So we use a deep learning model.
Is that the most likely model that other eosinophil disease research is using?
Yes, and so deep learning, I would say, is probably the most common model you'll see nowadays, because with as many data points that we're really trying to figure out and uncover and recognize patterns from, that I think is the model that really fits perfectly to develop that algorithm and the AI model for you. So deep learning is pretty common. The question is it supervised or unsupervised? So our model is a supervised learning model where we labeled things first and we taught it. And so the biopsy models currently today are supervised models. Thinking about an unsupervised AI model, this is where you would just give it photos of biopsies, or maybe you give it data of patient information, like some of those atopic diseases we're talking about, those ones where asthma was, the model was fed different data points, and then it developed its own pattern recognition and say, hey, these ones look like they all have asthma, or these ones look like they have more severe asthma. So an unsupervised learning model may be able to uncover patterns, as opposed to a supervised learning model, which will help you also identify patterns, especially if you're looking at something like EOE, where we want to look beyond the eosinophil count. Starting with a supervised model, I think, is the way to go.
Anyone else has questions, please feel free to open up the Q&A box. You can be able to enter your questions. We've got some great comments from people coming in saying great presentation, great potential. So thank you so much for all of that. I know I've got a few questions, and there's a few questions coming in here as well. So if you'd like, you're welcome to stop sharing your screen. Fantastic. Alrighty. Let's see. Are there any studies on AI in terms of non-invasive biomarkers of EOE?
Yeah, that's a great question. There were a couple, and these I was going to share, but it got a little bit in depth. So there's one looking at blood biomarkers, urine, and also endoscopic biomarkers. And the reason why I didn't share it is because they didn't have, there's so many biomarkers out there to really understand if what we're seeing is a true pattern or not. And so I do think that the biomarker process and identifying EOE patterns is definitely coming. Biomarkers on its own right now, so if we just looked at biomarker studies for blood markers, for example, of different eosinophil neurotoxins and whatnot, those weren't sufficient on their own to help us identify EOE. And so these ones looking at them on their own, I think, haven't panned out for us yet for EOE as in the diagnostic field. But if we start to combine them together and including other really unique biomarkers, a group in Orlando is using EDN on brushing in the esophagus, like those combined with what the biopsy looks like, I think would be really unique, in addition to, again, using these like huge learning models where we can input all of this data and be able to find a pattern. And so I think that's really where we're heading when we think about biomarkers. And then, what the outcome of that is going to be, I don't know, but I'm excited to see.
Absolutely. What is your biggest hope for the future of AI and eosinophil disease research?
Yeah, so actually my biggest hope is that I can start to identify different endotypes of EOE. So, those patients that come in that have maybe just some abdominal pain, and you end up doing endoscopy and you're so surprised that you found EOE, and it's, you're like, is this something that I really should be treating? Is this truly EOE? To what degree is that patient going to develop symptoms as an adult? And so if we have an ability to recognize a pattern, if we just think simply in their biopsy, that regardless of their symptoms, because symptoms can be subjective to some degree. So can we recognize a pattern that says this patient, even though they have no symptoms, should still be worried about them because they are at risk for potentially having fibrosis based on what we know, in longitudinal data and things like that. So I think that is probably where I would prefer to see the future going, is because we at this point treat EOE as if we're preventing a lot of things in adults. And I think to some degree, we are doing a fabulous job at preventing strictures, hopefully. But I think we probably could be a little bit more individualized in our approach. And so to what degree one patient that may be at more risk to having strictures should actually be on a different medication, as opposed to just trying out medications and seeing what works. And so that's that kind of individualized personal approach, but also with a risk stratification. And so, I'm always surprised when I find EOE when maybe the biopsy looks perfectly, or the endoscopy looks perfectly normal, or they have really non-specific symptoms, or even, patients that, boom, have no symptoms, and then they present with a food infection, So it's quite unique, the presentation that we see specifically in kids, where they're kind of all across the board. And if we can identify something in the beginning that can then help us say, as an adult, this is what your EOE would look like, and that's why we need to do this as a child, I think is where I hope to see it going.
We've got a question that came in here. As the models continue to improve, can you identify or predict where human in the loop interfacing needs might materialize?
So yeah, if you look at some of the AI literature and letters in medicine, there's this thought that, the physician role won't be, as important as the AI role. And so I think it's really important to know how we're going to meld the two. And rather than comparing like the EOE biopsy analysis to a pathologist read, that's not appropriate. We're not saying one is better than the other. Right now, we're just saying this is the standard, and I need to make sure this reaches the standard diagnosis. But I think more importantly, it's how the pathologist can use this to provide us the in-depth knowledge of what they can understand from an entire biopsy that I probably don't see. And so I think it's about melding the future that I see is probably working in combination to provide the best care for the patient that's really individualized. And a machine telling me, that I should buy this type of shoe because I bought this purse, I don't think you would want a machine telling you that this is your EOE and this is your medicine, take it. That you need that another level of understanding to say, well, you don't swallow pills that well. Why don't we try this? And I still think it fits in with this, what I'm seeing as a prediction factor based on the AI. So I think there's a really unique opportunity to meld the two and to have the physician and the AI work together to really make medicine unique and working together rather than saying one is better than the other. I don't know if that answered the question properly, but.
Please feel free to write back in if you have a follow-up based on that initial question that you asked. Is there a use for AI in being able to predict conditions like EOE based on family genetics? So the question that's coming in notes that, right now parents have to like spit in a tube for research. Could AI be used to help predict something in that fashion?
I think so. The article that I shared, or the study that I shared looking at mRNA just within the biopsy, to what degree that can be expanded to genetic code or material that we're able to get from spit sample or from blood samples, and then seeing how that pattern fits. I think there's definitely possibility in there, and one, identifying specific genes, and Cincinnati's doing a great job at like looking at different genetic patterns that I think could be expanded upon. And that's the beauty of AI, is because you would be so surprised at how much data goes into just one genetic code. And for one person to try to just look at that one thing, it would take years. And now to add on several layers of like, well, then what did the biopsy genetic code show, and this, and then the parents, combined with that, or a sibling, like I think the possibilities are really endless when we think about how many data points a model can really read in a second. So I don't personally know a lot about genetics to talk about it as well, but I do think that there's a huge potential for AI to help advance what we know in terms of genetics for all disease processes, including EOE.
So we're continuing to get lots of wonderful positive comments, including comments like, that was brilliant. So we've got a question here about protein folding and deep learning. So we've seen what deep learning can do with protein folding. Without lots of data, you can't do machine learning. So as a patient keen on sharing data, what can you say about like how people can submit their data for helping with things? This person happens to live in Switzerland and is curious about how things are shared within the United States, and just thinking about, looking ahead, how can patients participate?
Yeah, so, at this point in some of the studies that I shared for EOE, outside of the genetic studies, which I think probably has a unique opportunity to participate in certain databases, that different companies, or Seeker, for example, is a company or a consortium that's developed their own EOE database. So sharing your data within these databases allows people to allows researchers to utilize that database to practice their EOE algorithms. One really great study looked at biopsy results, very similar algorithm to ours, and I think they were out of Italy or Germany, and they didn't have the biopsy, sample width of EOE to really validate their model or hone in on a pattern. And so they partnered with Seeker and used their biopsy, as a research tool, grant funded, to use their biopsies to develop their algorithm and show validation and found patterns similar to what we were looking at. And so I think that's probably the opportunity where we can work internationally, is specifically with biopsies. With our model, I don't need your specific biopsy. If you are able to take the photo of the biopsy that works with our algorithm, that's enough, and we can take it further from there. And so I think there's an opportunity to really work, again, internationally, looking at biopsy, looking at photos of endoscopies, and then, in these larger databases where you can share genetic or share, different labs and sputum samples and things like that. I think there's definitely an opportunity to work together and to have these large data sets, even if you are not in the United States.
Wonderful. You talked a little bit about how this technology might be applied to other conditions, but that it's not quite there in other places. What do you think about conditions like hypereosinophilic syndromes? Do you think this kind of technology could be applied to research for HES?
Yes, absolutely. When you think about hypereosinophilic syndromes, I think there is a unique opportunity to use AI, and this is how I see it. Hypereosinophilic syndromes, at this point, we're looking at how many eosinophil counts you have in your blood. But that also translates into some patients that have eosinophilic infiltrate, meaning I take biopsies in the esophagus and I see eosinophils. They may have eosinophils there because of hypereosinophilic syndrome, or they may have it there because of EOE. And identifying possibly a pattern within the biopsy that says, this one doesn't quite look like EOE. Maybe if we start to feed in biopsies of patients that have hypereosinophilic syndrome, we're able to, then the model's able to identify a pattern that we can then use to say, this patient came to us because of EOE. They've had a little bit higher eosinophil count. I think this may actually be hypereosinophilic syndrome, and they should go and get a bone marrow biopsy, and maybe in the bone marrow biopsies can help identify that, but then they need to go and work with their hematologist. And so I think there is a very unique opportunity with the models that I shared with you in possibly identifying a pattern for hypereosinophilic syndrome if there's infiltrate within the esophagus. And now hypereosinophilic syndrome, you can get infiltrate within, a skin biopsy. And so I think there's definitely an opportunity to expand on that further.
So what's next for you and your research team?
Yeah, so next for us is, so we've validated our model, we've set it lots of data, and we've then used it to say, okay, here's all of our biopsies, can you find EOE? And it did it with accuracy. The next is really what I was talking about with some of the other researchers that have done, is started to find patterns. And those patterns, they were found in smaller cohorts. And so if we can use a large database of biopsies and start to identify patterns, maybe we can predict response to treatment. Maybe we can talk about, find those endotypes, does someone that has no symptoms at all and then have a food impaction look very different on a biopsy than those that have tons of symptoms and get into remission, so I think that is the next step that I'm hoping to take with this. And then, beyond that, how we can add in other biomarkers like, in the blood, in brushing samples and things like that, I think is even further.
Well, thank you so much for your time and all the information that you shared today. Really, really enjoyed learning more about artificial intelligence and how you've been using it. I also want to take a moment to say thank you to our education partners for their support of this webinar series. That includes Abbott, AstraZeneca, Bristol Myers Squibb, GlaxoSmithKline, Sanofi, and Regeneron. If you enjoyed today's presentation, we hope you will sign up for additional webinars in APFED's Eos Support Webinar Series. Our next webinar will be on December 8th, and it will feature Dr. Panda talking about oral immunotherapy and EOE. You can register for any of our upcoming webinars, as well as watch recordings of previous webinars at apfed.org/webinars. You can also continue learning about eosinophil-associated diseases by checking out the on-demand sessions from APFED's annual Patient Education Conference. You can check out apfed.org/conference shown on the screen in the bottom right corner, and you can be able to go watch all of the presentations from the conference this past summer on demand. You can also continue to explore the research hall as well as the exhibit hall through the end of the year. Another way to continue learning is through our podcast, Real Talk, Eosinophilic Diseases. In the latest episode, our co-hosts Ryan Piansky and Mary Jo Strobel had a great discussion about access to specialty care with Dr. Emily McGowan. You can subscribe to our podcast at apfed.org/podcast, as well as Apple Podcasts, Spotify, Audible, and more. Finally, to continue the discussion started today and connect with other people impacted by eosinophil-associated diseases, check out our online community on the Inspire Network at apfed.org/connections. If you have any additional questions, please don't hesitate to reach out to us. You can email mail@apfed.org. So thank you once again to Dr. Hopson for a wonderful presentation today. I hope everyone has a great day.
Thanks.